All right, thank you, Michael. Our next speaker is, we're honored to have Dr. Susan Buchbinder from University of California in San Diego, or San Francisco Public Health Department. And she's going to be talking to us about challenges with pre-exposure prophylaxis. Dr. Buchbinder, thank you.
Thanks so much. And I'm going to be talking about challenges and opportunities in pre-exposure prophylaxis. I don't have any financial disclosures. So after attending this presentation, you should be able to safely start and stop PrEP, counsel patients about what we call 2-1-1 PrEP, and describe new PrEP modalities. So let's start by talking about daily oral PrEP. We've had daily oral PrEP available since with TDF-FTC since 2012, when the US FDA and the World Health Organization both endorsed it. It was licensed in the United States for men who have sex with men and transgender women based on the IPREX study, and on heterosexual couples based on the Partners PrEP study, and a little bit of data from the Botswana TDF2 study. So I wanted to start with a question. How do you actually start PrEP? Do you wait for lab results? Do you start PrEP immediately, meaning same day? Have you not prescribed PrEP or something else? So go ahead and vote. Okay, so about half of you wait for lab results, and about a third start PrEP immediately, same day. So I'm going to talk about, and then 16% haven't started prescribed PrEP, but hopefully will before too long. So let's talk about same-day starts. These are data out of the New York City sexual health clinics, in which they took almost 1,500, a little over 1,400 PrEP candidates, and they asked them three questions, basically. First, did they have kidney disease history? Did they have a history of hepatitis B, chronic infection? And did they have any signs or symptoms of acute HIV? If the answer was no to all of those, then they got immediate PrEP. If the answer was yes to any of them, then they got delayed PrEP. Delayed PrEP only applied to about 3% of the population. 97% were able to start immediate PrEP. So what happened when they got their lab test results back? Well, in terms of having a GFR of less than 60 or being NAT positive, there were only 4 individuals, less than 1%, who had to stop PrEP because of a contraindication. So that meant that more than 99% were actually able to continue on PrEP. In the delayed PrEP arm, 7 people, or 14%, were disqualified from taking PrEP, although I will say that people who are surface antigen positive can take PrEP. They just should be taking daily PrEP. But 86% were eligible, but only 35% came back and started PrEP. So there is something to be said about a bird in the hand is worth 2 in the bush, and that when you have someone who's ready to start PrEP, you can do it safely as long as you screen them first. It's best if you can get a rapid HIV test, but if you can get test results back quickly, then you should be able to actually start PrEP, and then if you need to, you can stop it rapidly. So for whom does TDF-FTC PrEP work? Well, it works in men who have sex with men and transgender women, and you can see here on the right-hand side the HIV incidence that declined in a placebo-controlled, randomized controlled trial between the placebo arm and the PrEP arm. Same thing with people who inject drugs, and same thing with serodiscordant couples. But if you look at the subgroup who were completely adherent to PrEP, there was essentially no transmission. So PrEP is highly effective for both sexual and injection drug use transmission, and it's been now approved for everyone who's 35 kilograms or greater, meaning that there is no lower age limit to starting PrEP. It's just a weight limit. So how do you start and stop PrEP? Well, what we can look at is the EC90 of tenofovir in the peripheral blood mononuclear cells, and 89%, you achieve 89% of maximal concentration at 7 doses. So for men who have sex with men, 7 days before is adequate. But you can also just give a double dose. You can give basically what's like a loading dose. And we'll talk about 2-on-1 PrEP, but that's how that's administered. And so that's demonstration that you get high enough levels that you don't need to achieve your maximum concentration, that you get high enough levels after 2 doses. And for women, the CDC still recommends 20 days before, but there's a growing consensus among pharmacologists that 7 days may be adequate. Now, the level of tenofovir in vaginal tissue is 100 to 1,000-fold lower in vaginal tissue than in rectal tissue. And so for that reason, you need to wait until the titers get high enough. So we do say wait 7 days, and also that women need to take 6 to 7 doses a week for maintenance. So when we counsel women, we say you really need to try to take this on a daily basis. For men who have sex with men, if they're taking daily PrEP, but they miss a dose or 2, 4 doses looks to be almost as highly effective as 7 doses a week based on modeling studies. So you can say to men, if you miss a dose here or there, don't worry about it. In terms of stopping, CDC still recommends 28 days to stop, just like it was post-exposure prophylaxis. But for men who have sex with men, we have data from 2-on-1 PrEP that's highly effective that suggests that you only need 2 days after your last sexual act to stop. And for women, likely 7 days is sufficient. So men who have sex with men, either 7 days before or a double dose, and stopping 2 days after the last dose. For women, 7 days before and 7 days after. What about transgender individuals? And these are data from the iBreathe study that took 24 HIV-negative transgender men taking testosterone and 24, I apologize if you can hear the sirens in the background, 24 HIV-negative women, transgender women who were taking estradiol. And then they put them on directly observed therapy with daily oral TDF-FTC for 4 weeks, and then measured the concentration of tenofovir and hormones in their blood. And here's what they found. I'll just orient you first. The blue lines are the baseline. The red are the week 4 data. And transgender men are shown on the left, transgender women on the right. This is plasma estradiol, and this is plasma testosterone. So if you look at the plasma estradiol in the transgender women, you can see that it essentially did not change from before and after. And if you look at plasma testosterone levels in transgender men, it also did not change before and after. And so you can reassure your transgender patients that taking daily TDF-FTC will not interfere with their hormone levels, because that has been a real concern voiced by the transgender community. What about the effect of these gender-affirming hormones on tenofovir concentrations in dried blood spots? You can see that there isn't a really significant difference between the transgender men, cisgender women, transgender women, and cisgender men. They're perhaps a little bit lower in transgender women, but they're still adequate for protection. And so, again, you can encourage your transgender participants to continue on their gender-affirming hormones, and they can still take PrEP and have it be effective. So what about people with renal dysfunction? Well, there have been studies in multiple populations that looked at an endpoint of having your GFR drop below 70. And it was higher likelihood of having that happen if your baseline estimated GFR was less than 90, if you were 40 to 50 years of age or older, if you were a lower weight, 55 kilograms, less than 55 kilograms, or if you had higher adherence, then you might bump your creatinine or drop your estimated GFR. But the creatinine bumps, when they get confirmed, are often unconfirmed on repeat testing. So that's a good thing to do as a first step. Creatinine reverts to near baseline after the trial, and the rechallenge has been used successfully in individuals who did bump their creatinine, stopped PrEP, and then restarted. Nonetheless, there was a question about could FTAF be used as PrEP? And so the Discover trial studied only men who have sex with men or transgender women. So there were no cisgender women in this study and no people who inject drugs. But men who have sex with men and transgender women were randomly assigned to either get FTAF or FTDF, and there were nearly 2,700 per arm. And they followed them for a prolonged period of time. And these are the demographics. What you can see is that, unfortunately, they only recruited 9% African Americans, which is not reflective of the population that is becoming infected currently. And the proportion who were transgender women was under 2%. And so, again, not necessarily reflecting the population. Nonetheless, what they found was that by week 96, TAF-FTC was non-inferior to TDF-FTC. So it wasn't superior, but it was non-inferior, suggesting that you can use TAF-FTC as PrEP, particularly when you have concerns about renal or bone toxicity. What about renal and bone toxicity? Well, they looked at safety at 96 weeks and found that there were 2 areas that favored FTAF, but only by a very small amount. The bone mineral density loss was only 1 to 2% at the spine and the hip in the TDF-FTC arm compared to the TAF-FTC arm. And there was no difference in fracture rates. And then in terms of renal function, there was only a 4 milliliter per minute difference in estimated GFR at 96 weeks. So while there was some benefit to FTAF for bone mineral density and renal function, it wasn't a substantial difference. Similarly, the things that favored FTDF were lipids and body weight, but again, small differences, an 11 milligram per deciliter lower total cholesterol, no difference in the total cholesterol to HDL ratio, and the body weight, 1 kilogram difference in body weight. So our colleague, Julia Marcus, created this infographic for providers that compares TDF-FTC to TAF-FTC. You can see the pill size is different, so that might make a difference for some individuals. TDF-FTC is the universal PrEP agent because we know it works in men who have sex with men, trans women, heterosexuals, and people who inject drugs, whereas only that's the only drug that should be used for heterosexuals and people who inject drugs because we don't have data on TAF-FTC for either of those populations. And currently the licensed indication for TAF-FTC is not to give it to people who are having receptive vaginal sex. In terms of safety, marginal improvement in terms of GFR and hip bone mineral density for TAF-FTC, marginal benefit for TDF-FTC for LDL and body weight. Probably one of the biggest differences right now is that the cost is now close to $2,000 a month for TAF-FTC. And with new generics just coming online, you can get TDF-FTC for as low as $1 a pill or $30 per month. So there's a huge difference in cost for people who may not either have insurance or may not be able to access the patient assistance programs. We are also not doing well enough in terms of PrEP coverage for people age 16 years and older. The goal is to get to 1.2 million individuals who appear to be eligible for PrEP, and we're less than 20% of the way there currently. And PrEP is one of the 4 pillars of the ending the HIV epidemic as part of the national plan. You can see that men are doing better than women, where only a little over 6% of women who are eligible for PrEP are on PrEP. We're doing better in the middle age ranges rather than the younger people and the older people. So those are people we need to consider. And then we have these really substantial racial and ethnic disparities, which is really a problem because the rates of new infection are highest in Black or African American individuals, followed by Latinx individuals. And those rates of PrEP uptake are substantially lower than what we see in white individuals. And then there are regional differences. So the darker colors here indicate lower levels of PrEP use. And you can see, particularly in the Southeast, that makes up more than half of the new infections in the country, the rates of PrEP uptake are lower. And it's not surprising that that's also where we have less Medicaid expansion. So what about not just PrEP uptake, but PrEP persistence? Do people stay on PrEP? And these are data from a national sample that looked at PrEP use, people who initiated PrEP in the blue bars, and then how many were still on PrEP 1 year later in the orange bars and 2 years later in the gray bars. And while it's true that some people may no longer need it, what we've seen is that people who go off PrEP prematurely, and that accounts for a substantial number of people, and many of them don't discuss it with their provider, are at increased risk of becoming HIV infected. And what you can see here is that there is a tremendous drop-off by 1 year in terms of the number of people on PrEP, and that the drop-off is steeper in the younger age groups than in the older age groups. And similarly, we see steep drop-offs in both men and women, but a steeper drop-off in women than in men. So we need to find ways to continue PrEP in individuals who start PrEP, and to help them work through, for instance, startup syndrome or questions about whether or not they still need PrEP. We also know that PrEP has been really badly hit in terms of PrEP programs by the COVID epidemic. And these were some data that were presented recently looking at the Fenway Community Health Center in Boston and the Magnet Clinic in San Francisco, where there was a real decline in PrEP new starts following the start of the COVID pandemic, and PrEP refill lapses went way up. And here in the orange bar is the PrEP services, and you can see that it just plummeted in April of 2020. So we've seen a rebound in a number of programs coming back up, but not yet achieving the pre-COVID levels of PrEP administration. So why is it that people who may benefit from PrEP don't take or stop PrEP? And I divide this into 5 different buckets: sexual risk, access issues, concerns about medication, stigma-related issues, and then just life events. And so there are a number of consistent problems that aren't going to be solved by PrEP choice necessarily. People who have low self-perceived risk, if there are a lack of providers or there are cost or insurance issues, medical mistrust, or concern about being labeled as high risk, those things may not be alleviated by a different PrEP modality. Whereas some things might be benefited by either an on-demand regimen or a long-acting regimen, like infrequent sexual contact, difficulty adhering to visits or lab schedules, specific side effects or not wanting to take a daily pill, or privacy issues. So let's turn then to talking about on-demand prevention. And I want to start by just reminding you about post-exposure prophylaxis for non-occupational exposures, because it's really underutilized. So these are data from 10 US cities with the greatest overall HIV prevalence. And the providers were asked if they were aware of PrEP. This is a survey that took place in 2014 to 2015, but this is still several decades after non-occupational PEP was recommended by the CDC. And still 18% of the non-HIV providers were unaware of post-exposure prophylaxis, as well as about 4% of the HIV providers. But if you ask them, have you actually ever prescribed PEP, about 2/3 of the HIV providers had prescribed PrEP. Less than 1/4 of the non-HIV providers had ever prescribed PEP. And so it is something to remember to talk with your patients about, that if they have a high-risk exposure, that they should get post-exposure prophylaxis if they're not on pre-exposure prophylaxis. If they're already on pre-exposure prophylaxis, they don't need post-exposure prophylaxis. But it needs to be taken within 72 hours, but the closer the time to the exposure, the more effective it's likely to be. So let's talk about the big on-demand regimen that's called, we call 2-1-1 PrEP. And that's because it's 2 pills, 2 to 24 hours before sex. The heart and the smiley face is supposed to be sex. And then 1 tablet 24 hours later and another tablet 24 hours after that. And this is an infographic from the Ipergay study that tested this regimen. And if you had more sex, then it could be called 2-1-1-1-1 because you continue to take daily pills every 24 hours until 48 hours after your last sex. So And if your last pill was within 7 days, so if there's a hiatus and then you have sex again and you're going to restart, but it's been less than 7 days since you took your PrEP, then you don't need a loading dose. You just need a single pill, again, 2 to 24 hours before, and then 24 hours after that, and 24 hours after that, until 48 hours after your last sex. How well did it work? Well, they did both a randomized controlled trial and an open label extension. In the randomized controlled trial, it was 86% efficacy, and 97% effective when they had an open label extension to the study compared with the placebo arm in the randomized controlled trial. So very highly effective. There are some places where you can't use 2-on-1 PrEP, so I have this head-to-head comparison here. Who can use it? Oh, it's only been studied in men who have sex with men. We don't have data yet on transgender women, and we think that for cisgender women and any vaginal or potentially neovaginal exposures where we don't have data to suggest that you can use 2-on-1 in those situations. It's only been tested with TDF-FTC, not with TAF-FTC. So if you're going to use TAF-FTC, it should be daily PrEP. If somebody has chronic hepatitis B infection, then you don't want to use 2-on-1 PrEP because you can trigger a flare by going on and off PrEP. You do need to plan. So you need to be able to plan sex at least 2 hours in advance, and people have very innovative ways of doing that. Some wait 2 hours and then go on a geolocating, a sexual hookup app. Some people open a bottle of wine with their date and wait for the 2 hours, but not everybody plans. And so if you can't plan, then daily PrEP is better. And there isn't the same kind of forgiveness of missed doses. I mentioned that with men who have sex with men, you can miss doses and PrEP still is highly effective, but not so much if you're on 2-on-1 PrEP. So what's the 2-on-1? The World Health Organization has advocated for 2-on-1 PrEP. And I just wanted to mention briefly that there may be other on-demand agents coming down the pike. This is colon cell tenofovir regimen concentrations, and they're quite high in with tenofovir douches, and you can see that in a non-human primate Shiv challenge model, the douche work better even than oral TDF-FTC. So I'm going to end by briefly talking about long-acting PrEP. Cabotegravir, which you heard about earlier today, long-acting injectable, 21 to 50 days when it's injected. The HPTN-083 study in men who have sex with men and transgender women globally, HPTN-084 in women in sub-Saharan Africa, both had 3 steps: an oral lead-in, an IM loading dose at 0 and 4 weeks, and then every 8-week injections, and then oral doses to cover the tail, because there's a period of a year or two where you might have low enough levels that it doesn't provide protection, but high enough that it selects for resistance. And both used TDF-FTC as the comparator. There was a 66% reduction in risk of cabotegravir compared to daily oral TDF-FTC in men, and 89% in transgender women, in cisgender women. This was, both of them showed that it was superior, but there are some remaining questions. One is how best to diagnose infections on cabotegravir long-acting. There are delays in diagnosis because of delayed seroconversion, and so in the open label extension study, they will be using viral load testing for diagnostics. Why did the breakthrough infections occur? There were 16 breakthrough infections, and while we understand why some were infected at baseline, 5 were infected after a hiatus from CAB, but 3 were infected during the oral lead-in and 4 with on-time injections of CAB-LA. So those still need to be explored. How common will integrase inhibitor resistance be? 5 of the 16, or 31%, had integrase inhibitor resistance, but they responded to a boosted PI regimen. They didn't see integrase inhibitor resistance in that tail that I talked about, but more data are needed. We need to know whether we can go direct to inject without the oral lead-in, and we need to figure out how we're going to administer every 2-month injections in a streamlined way. And then finally, islatravir and lenacapavir. I think you heard about these earlier. Islatravir is an NRTTI. It's being evaluated as a monthly pill for men who have sex with men, transgender persons, and cisgender women. It's going to be evaluated as a yearly implant, possibly with contraception. And lenacapavir, as the capsid inhibitor, is going to be evaluated as a semi-annual subcutaneous injection for men who have sex with men, transgender persons, and cisgender women. And these studies will also look at TAF-FTC for women, so that we'll finally have data on whether or not TAF-FTC can be used for cisgender women. And then finally, dapivirine vaginal rings, only 30% efficacious in the RCTs, 50% in open label extension, has been approved by the EMA and WHO, and there are new agents and combinations and less frequent replacement of the vaginal rings that are currently under development. So in conclusion, we have highly effective PrEP and PEP options with more under development. CAB-LA is the latest product, but we have a robust pipeline of monthly pills, semi-annual subcutaneous injections, annual implants, and possibly vaginal rings. We have challenges with uptake and persistence in all populations, but particularly for youth, people of color, women, and people who inject drugs. And so long-acting agents are going to resolve some of these, but not all of these problems. And we need to offer choice and provide support tools to keep people on PrEP during periods of risk. And with that, I will take questions.
Fabulous. That was a wonderful review, Susan, and on time, on top of everything else. We got a lot of questions, so let me start with kind of a practical one from Rhett Brown, who asked, many insurance companies require a PA before I can prescribe this, and they also require a BMP and an HIV test. What are your thoughts on ways to navigate? I mean, the BMP and HIV tests sound logical.
You're going to get those anyway. It makes it more difficult to do same-day starts if you've got to do a prior authorization. And, you know, now it has a class, it's been recommended by the U.S. Preventive Services Task Force. So we really should not be requiring a prior authorization for it. If there is a way to get around that, that should start to go away given this recommendation.
Yeah. Another question, this is from Katrina Whiteside, asking about this craziness of, well, you can use TDF FTC in women, but you can't use TAF FTC in women. And maybe you can explain why the studies haven't looked at this, or what the status is on that.
Just a huge oversight on the part of the Discover trial that they only enrolled men who have sex with men and transgender women. And so we just don't have the data on cisgender women. We expect that it will work, but we don't have the data yet. So the good news is that there is a trial that's launching with lenacapavir, in which they will have two arms. One will be TDF-FTC, but one will be TAF-FTC in the women's study. And then the third arm will be lenacapavir. So we'll finally get some data on TAF-FTC. Again, we think it works, but the recommendation and the license indication does not allow for TAF-FTC for individuals having receptive vaginal sex.
Thanks. Megan Nukla wants to know about transgender populations, and if adherence drops, say, to 4 doses a week for MSM or 6 doses for women, transgender women, but they're on hormones, they're on hormone replacement therapy. Is that still safe? What is there a threshold that you say watch out for?
Yeah, I think with the latest data on the PK on women on transgender women on TDF-FTC, it looks like their levels are high enough that they can also potentially get by with 4 doses if they're having receptive vaginal sex. If they've got a neovagina, we just don't have any data on concentrations there and what the likelihood is of risk of transmission there. So, you know, there may be some nuances to that, but I think the PK data are now supporting that that we don't have to worry so much about levels in transgender women.
Yeah, and I think also you and I have talked about this a bit, about which is more important, the actual levels at the epithelium or the mucosal level, or at the receptor level of the T cells that might become infected that are circulating and passing through. And I don't think we've answered that yet.
Right, and I think that's very important, because with the women, it may be that they can also get by with only 4 doses, at least with lower levels of adherence in the demonstration projects. It looks like women have done very, very well. So we may be being overly conservative.
Jonathan Samuels asks, what about TAF for heterosexual men?
Yeah, we don't have data specifically on heterosexual men, but what we know is that some of the MSM presumably were getting infected through being the insertive partner, not just the receptive partner. So we think that basically the licensed indication now is for everybody for sexual transmission except for receptive vaginal sex. So we think that it's okay for heterosexual men.
Angel Bakshi asks, what about the increased rates of STDs or STIs after starting PrEP?
That's a real problem. So we were seeing rises before this happened, before we got PrEP. We've seen more rises with PrEP. I do believe that there probably is less condom use because of PrEP, and there are, the data are mixed, but I think that there is some truth to that. I think we need to counsel people about the risk, and we need to be screening people on a regular basis. So our recommendation is every 3 months for everyone. CDC says you can go to every 6 months for screening, but we screen everybody for STIs in 3 locations, oral, anal, and urine. For anyone having anal sex on a 3-month basis, because we do need to pick up those STIs. There also are some interesting studies going on right now with doxy post-exposure prophylaxis with doxycycline to see if we can prevent STIs as well.
Megan Turchek asks about barriers to getting people in a timely way into the clinic setting to start the PrEP. And outside of education, any tricks that you can suggest to make that happen faster or more efficiently?
Well, I think that what clinics need to do is to look at having as low a barrier as possible to getting people in. And a number of clinics are doing sort of express clinics for PrEP to get people in and out quickly. It doesn't really take that much. And then certainly for the refills, a lot of clinics are going to just an annual visit with a provider and having a nurse or even a peer-led educator doing you can do the screening very quickly, do phlebotomy for the blood work that you need done, do self-swabs, and get people in and out as quickly as possible.
I'll squeeze one more quick question from Mark Elam about somebody who's having trouble with the adherence of a pill, the use of injectable cabotegravir every 4 or 8 weeks. Is that going to be a future option?
It should be by the end of this year or sometime early next year. We think that cabotegravir, long-acting injectable, will be an option for people for PrEP.
So there are a few more questions in the Q&A that we'll try to get to, at least by typing in answers to the folks, and these will be posted for you, but we have to wrap up the session. Thank you so much. Wonderful, wonderful presentation. Very timely and informative and just comprehensive. Thanks.
Yeah.
So we're going to take a 30-minute break, and then we'll be back at about a quarter after the hour, depending on where you are. It'll be either 3:15 or 2:15 or 1:15 or 12:15. Or if you're in Singapore, I can't do the math, but it's going to be sometime in the morning. But 15 minutes after the hour, we'll take a break, and we'll be back then. Keep your eye on the clock. It'll count down for us when we're going to be coming back. Thanks.